Welcome everyone to this International CML Foundation's key discussion on CML Latin America. This is the last one of a great series for 2025. I'm Arlene, I'll be your moderator today. And before I introduce our speakers, I'll take a moment to let newcomers to the foundation know a little bit about who we are and what we do. So we are a physician and researcher-based foundation with two key priorities, both working towards improved outcomes for CML patients worldwide. Firstly, we are raising the bar of CML management through CML education, and that includes meetings like this. Over the last 15 years, the foundation has been working via preceptorships, in-person meetings, and online with our case discussion forum and the Knowledge Center, trying to make sure that no matter where you are in the world, CML physicians and researchers have access to the best possible knowledge, opinions, and experience. The other side of our work is harnessing the power of global research. Our ideal is working towards a cure for CML, but along the way, we're trying to improve treatment pathways and patient outcomes as much as possible. So we have the Genomics Alliance, we have the TFR Alliance, we did a lot of work around CML and COVID, we have a hepatitis B survey which rolled out recently, and if you missed it but you'd like to contribute, please get in touch with me as soon as possible. We're also looking at CML and pregnancy in low and middle income countries, pediatric treatment in low and middle income countries, and there's much more to come. So that's just a brief overview of the International CML Foundation, who we are and what we do. Please reach out to me if you have any questions or you want to know more about our programs. So on to our discussion today, which covers two topics, molecular monitoring and aspects of mutation analysis that should be considered for CML management in Latin America, and Sanger versus NGS for mutation analysis, applicability in real-world Latin America. So I'll introduce our speakers right after I've done some housekeeping and logistics. So this is an interactive meeting. Everyone is welcome to contribute, ask questions, make comments, but for everyone's comfort, please keep your microphone switched off until you actually want to be heard. By contrast, it's really nice for our audience and for me as a moderator to feel like we have a real audience of real people. So you're welcome to leave your cameras on. You can submit your questions or comments via the chat or raise your virtual hand. If you have any logistic questions, contact our host today, Nicola Evans, via the chat. Interpretation questions, please send your message via chat to Veronica, our interpreter. So our first topic for today is molecular monitoring and aspects of mutation analysis that should be considered for CML management in Latin America. And I'm delighted to introduce our first two speakers for today. Dr. Lilian Pilleux from Valdivia in Chile is our regional expert for this topic. Lilian is a great physician and researcher. She sits on the steering committee for these Latin American key discussion and CML meetings and is massively supportive of the foundation. Lovely to have you presenting today. Lilian, we are greatly privileged to have you back.
Thank you. Nice to be here.
Lovely to have you. Professor Sue Branford from the Centre for Cancer Biology, South Australia Pathology in Adelaide, Australia, is a giant in the CML field who is preceded by her reputation and back in the Latin American discussion series by popular demand. Professor Branford is a great friend and frequent contributor to the Foundation's work, and it's always an honour to share the floor with you. Welcome, Sue.
Thanks, Arlene.
So I will take my slides down and invite Lilian to get her slides up, please. And as Lilian is getting her slides up, I'll tell everyone that Lilian will spend 10 minutes presenting her first case. Sue will comment on it, and then we'll open to the other experts and you, the audience, for questions and comments, and then the same with the second case. Also, whilst I will properly introduce our other experts later, I'm pleased to tell you that Dr. Isabel Guerri and Professor Jerry Radich are already present, and they will make their presence known for this meeting too. Okay, Isabel, you are ready. Over to you.
I'm Lilian Pilleux from Valdivia, Chile, and this city is located 800 kilometers south of Santiago, so you can see where we work. I have prepared two cases. The first one is a 76-year-old man that was fit, and in September 2023, started with abdominal pain that made him go to the emergency room. There they found that he had a splenomegaly, 3 centimeters under costal margin, and took some tests, and the complete blood count showed that he had a leukocytosis and thrombocytosis with a left deviation of the formula and basophilia. He had a high LDH and had a history background of arterial hypertension and was a smoker. He was taking a couple of meds for that disease. So he started hydroxyurea the same day and aspirin, and was performed a PCR for BCR-ABL that was detected for the P220. And the bone marrow studies show that he had a low percentage of blasts, and the CT scan confirmed he had a mild splenomegaly. The karyotype showed 100% Philadelphia chromosome without any additional chromosomal abnormalities. So we calculated or diagnosed a high-risk score for his CML and intermediate for ELTS. We decided, because of his comorbidities and his age, to start therapy with imatinib. He tolerated it well, but had some facial edema and moderate hypertension. So he had at 3 months, he had reached complete hematologic response, but didn't get an early molecular response. But later he has achieved MR3 until 14 months or 15 months, and he started to rise, and he lost MR3 at 15 months. So we had some doubts about his adherence to therapy and told him to come back in 2 months. This is the curve of his qPCR, where at 15 months, we see that he loses his MR3. And then we decided to perform a mutational analysis by Sanger sequencing, and found out that he had this mutation, the M244V. So we had the doubt, or we wanted to know if this mutation was present the months before, and performed Sanger sequencing to 2 other samples before the one that was diagnostic in May 2025. We repeated the sequencing for April and for December in 2024 that were available. And we found out that the mutation in the Sanger sequencing was present in both in the 3 samples, and the sample that had the highest PCR was the last one, that was 16.0, and the one that had 14.6% had the same mutation without any remainder of the wild type. But the one that had the qPCR of 0.16 had a little bit of the wild type that was still visible. So my questions would be, first, if you would consider this case as a secondary resistance, taking into account the brief period of optimal response. Also, in our case, the mutation that explains resistance is dominant. What would be the role for performing ABL mutation analysis by NGS? And the third one, which TKI would you recommend for second line in this patient for the M244V mutation.
Thank you, Lilian. Beautiful presentation there. Sue.
Yeah, so I think there's a couple of things there that are interesting. The first thing is the BCR-ABL value 3 to 4 months after starting TKI was 21%. So that's in the range where you would consider that the patient is in a warning category. And certainly the European Leukemia Net would recommend additional testing within 1 to 3 months. And at 6 months, the patient did have a major molecular response. So they had a dramatic response after that initial high level. So if the BCR-ABL value had been greater than 10% at 6 months, then that would have indicated primary resistance and a change of therapy would be recommended. But in this case, the patient had a very good response. So I think you did the right thing. A rise in BCR-ABL certainly triggers BCR-ABL, and that's exactly what you found. And tracking back, you found evidence just at the start of the rise that the mutation was present. So I think that's typically what we see, is that as soon as the BCR-ABL starts to rise, that's when you can detect the mutation. So in this case, it was a very dominant mutation. So the question is, what would be the role for performing ABL mutation analysis using next generation sequencing? So I'm assuming that the test was performed using Sanger sequencing. So I think that's probably the method that would still be used most frequently around the world. It's a very good method. The only issue is that it's not as sensitive. So next generation sequencing methods specifically to sequence the BCR-ABL, amplicon, the kinase domain and surrounding region, does provide more sensitive analysis. But in this case, as you've shown, that Sanger sequencing was all that was needed here. Even perhaps using next generation sequencing, if you tracked back even to an earlier time point before the rise in BCR-ABL, I think the patient was still in a major molecular response. Maybe you could detect that mutation earlier. But if the patient is responding, there's really no trigger for mutation analysis. So it's only when the BCR-ABL starts to rise that would be the trigger. So in this case, and perhaps for most cases, Sanger sequencing is adequate. So coupled with a rise in BCR-ABL, the mutation detection, I think it gives you more confidence that this is a true biological resistance as well. Sometimes we start to see a rise in BCR-ABL. We'll contact the clinician before we do mutation analysis and ask, is there any reason why there might be a rise in BCR-ABL? Because we know that when patients stop therapy, they may have some intolerance or some non-adherence, then that's when we can see BCR-ABL start to rise. But in this case, the detection of the mutation indicates that there is a true biological cause for the rise in BCR-ABL. And the M244V, so this was one of the first mutations that we detected in patients many, many years ago when patients were developing resistance to imatinib. So it is an imatinib resistant mutation. It's just outside the phosphate binding loop, the P loop. In our experience, it's for imatinib treated patients, it's not a particularly common mutation, but I would consider it is a relatively mild mutation for imatinib, and patients would be potentially responsive to a switch of TKI. So in this case, a second generation TKI, nilotinib, bosutinib, or nilotinib in terms of sensitivity would be appropriate. But I think this patient did have some hypertension at diagnosis.
Yes,
Yeah, so in this
and
case,
continued.
yeah, in this case, dasatinib would be appropriate. But I'd also like to mention that I'm not sure if asciminib is available in cases of resistance in Chile, but certainly in other countries it is approved. And work that has been done over the last year has actually shown that this mutation causes resistance to asciminib. So the NCCN guidelines now incorporate into their contraindicated mutations for asciminib, the M244V. So I think it's really important now for clinicians to be aware that there are more and more mutations now that may be sensitive to the second generation inhibitors, but potentially could be problematic for allosteric inhibitors. So I would suggest that clinicians carefully check the latest guidelines for asciminib resistance. And there was just one other thing that I thought would be useful. So you mentioned that the patient has the P210 BCR-ABL, so that was determined at diagnosis. So how was that determined?
By qualitative PCR, by
Yeah.
a kit.
Okay, so a qualitative PCR, so it doesn't actually, I'm assuming a qualitative PCR followed by perhaps running on a gel and determining the size of the amplicon, so you can determine whether it's a P210 or not.
Um, I think we don't run it in the gel. It's just real-time PCR.
It's a real-time PCR, okay. Just I thought I'd raise that because there may be some labs who are running on a gel to determine what the size is. And again, being aware of asciminib newest allosteric inhibitors, there is also some more work done over the last year to show that patients who lack ABL exon 2, which is a rare atypical BCR-ABL transcript, they will also have resistance to asciminib. So I think it's becoming important now that the methods that characterize P210, because this BCR-ABL lacking A2 atypical transcript may look very similar to a P210. So it is also a P210, but it could cause resistance to asciminib. So that would be my comments, that clinicians have to be aware these days. There's a few extra things that we need to think about with the new allosteric inhibitors.
Jerry, I might invite you to comment.
Sure. Well, first thing, as Sue pointed out, the really interesting thing up front of this patient, and I know Lily, you said that there's a question of whether he was adhering to his drugs. As Sue pointed out, that his data suggests that probably not early on, right? Because going from 4 months to 6 months, he has almost a 3 log reduction in his dose, which biologically doesn't make a lot of sense. But it makes a lot of sense if they weren't taking their drug for the first few months and then decided that when they saw a 21%, the fear of God was placed in them, and they went on it. So I I think that's probably what happened. The other thing about the next generation sequencing, as Sue said, it's looking at it after the fact. You might find it earlier on with next generation sequencing, but like I said, if you got a great response, that's what really kind of drives your behavior. And if the patient was having a great response but still had a mutation at a very, very low level, I don't think anyone would really jump to change drugs because clearly it's not driving any resistance at that point. The other thing you have to think about when you use next generation sequencing is if you really do very, very, very sensitive sequencing, like duplex sequencing, when you get down to 1 in a million mutations, um, you can pick up mutations at a very low level that actually aren't disease but are artifact and look like typical mutations. And that's because when you do the calculation, if you start with RNA and then make your libraries out RNA, you introduce a relevant mutation in about one per one out of every 21 to 25 cDNAs you make. So you have a high risk of introducing very low background mutations that if you just happen to amplify that one, you'll get a signal. And in fact, when we've gone back and looked at chronic phase CML patients, even by this ultrasensitive stuff, at diagnosis, you don't find mutations there. So they still might be there, but if they're there, they're less than 1 in 10 to the 7th. But you can pick up things where a mutation comes up and then goes away, and you say, gee, that doesn't make any sense biologically. It's because it was artifact and there is no biology to it. So just like any other technology, as you get more and more sensitive, you also get more and more, potential false positives. There's no way of getting around that.
So at the diagnosis, you would recommend to size the length of the amplification amplicon
I would think
to
so.
be sure.
I think these days, yes, unless you've got a method that precisely tells you whether it's an E14A2, E13A2, or something different, I think it's very important. And perhaps if there is a gel running sequencing to confirm the exon junctions these days is really essential.
Oh, okay.
Isabel, what are your thoughts?
Thank you. I think that's very important to characterize the isoform of the P210 because we know nowadays that there's another factors that could give resistance to new TKIs. The case is very interesting, and I think it was very well evaluated in the region. The Sanger sequencing method is a good method, such as Susan said, and all we know. And nothing to say more. Nothing more to say.
Very well.
So then I'll go to the second case. The ending of this case first. This patient was switched to dasatinib, and when we knew he had this mutation, and he rapidly at 3 months lowered his qPCR, and now last month is at 0.22% of this qPCR. So it's in a good way for recovering his MR3. And the second case is another man that was 48 years old in the year 2016 and was diagnosed with a chronic phase CML. He had started with weight loss and abdominal pain, and when he decided to go to his doctor, had a splenomegaly of 5 centimeters under the costal margin. He had severe anemia and hyperleukocytosis with 9% blast in his formula and basophilia. Had a high LDH, and the CT scan confirmed important splenomegaly with a spleen of 27 centimeters. And he also had a history of arterial hypertension and mild alcohol abuse, and was taking these drugs. He lived in like 400 kilometers south of Valdivia and had to travel like 8 hours on bus to go to his controls. So at diagnosis, once again, the BCR-ABL P210 was detected, and the karyotype didn't have any additional karyotypic or chromosomal abnormalities, and had a high-risk SOCL and ELTS scores. And he started with dasatinib. He had this was his response. He had a early molecular response at 3 months, and he at that time we didn't have the qPCR so often available, so we have his first MR3 at 18 months, and so forth. He maintained it until during his third year in which he started to rise, and had one value of 0.13%. At that point, we requested a mutational analysis that wasn't performed in our lab, but it showed a T315I mutation, and he was still in complete cytogenetic response. This is the curve of his qPCR, in which it appears the moment after he started to rise. So he was switched to ponatinib, that was started in July 2020 at 30 milligrams a day, considering that he was still in complete cytogenetic response, and recovered his MR3 after 2 months. During COVID pandemia, he had bad adherence to therapy. He even missed taking his drugs some months, but he still maintained MR3. In June 2022, he was lowered his doses to 15 milligrams a day and achieved MR4 in August 2022, and afterwards has remained in MR 4.5 to 5 and his last control. And from last year, he has a year he's taking 7.5 milligrams a day. So my questions in this case are, is it feasible to search for the T315I mutation, and does it have any clinical value? If he remains in deep molecular response and completes 24 months undetectable, would you consider TFR? That's a more clinical question.
Thank you. Another great case, Lilian. We'll start again with Sue, please. And while Sue is commenting, can I remind everyone, please, that this is an interactive meeting. You are welcome to post your questions or comments in the chat or use your virtual hand, and I'll invite you to speak. Thank you, Sue.
Okay, so the questions, is it feasible to search for the T315I? Can you just clarify, do you mean now that the patient is in MR4, 4.5?
Yes, yes, because according to the international recommendations, he wouldn't be a candidate for TFR, but we don't know what happens with patients who have had mutations. If they are not detectable, maybe it would be a case to try stopping the ponatinib.
Right. So there's a couple of things. It's quite an unusual case to have to have such a sort of a relatively small increase. It was just over twofold, and the T315I was detected. Was there any repeat? I think that's something that we would certainly want to see, perhaps another test done, confirm that the T315I was present.
I know that the reference lab, we sent it to Santiago, and that time repeated the test with the same sample, but didn't ask for another sample.
Right.
But we didn't. It wasn't easy to finance the test, so we did it once. But they repeated it locally.
Okay, so at least it was confirmed on repeat, and I think that's important as well. You know, as Jerry was mentioning previously, we have to be aware that we're not reporting false positives. The patient had a good response to ponatinib. In terms of if the patient would qualify for a TFR, certainly there have been a few reports. So the Hammersmith have looked at this. I think they've looked at 10 patients who have had various missense mutations in the kinase domain. They published their data, I think it was in about 2020. And there were 2 patients who did have T315I, and they found that 5 of the 10 patients, once they qualified for treatment-free remission, the usual qualification, maintaining deep molecular response for 1 to 2 years, etc., then 50%, 5 of the 10, were able to maintain TFR. So it's a small cohort, but it certainly did demonstrate that it is possible. I think the concern with this patient is that there has been a history of non-adherence, not only, I think you mentioned, to taking the drug, but also non-adherence for having the appropriate number of tests, and can completely understand how difficult it is if the patient has to have an 8-hour bus ride to get tests. So to qualify for treatment-free remission, the recommendations are 1 to 2 years of a deep molecular response. I think there are some guidelines that say that have at least 4 tests over that time and be in at least an MR4 every time point. And then once the patient stops TFR, the recommendations still are to have really frequent testing every 1 month for the first 6 months. Is the optimal to see, because we know that if patients are going to relapse, it mostly occurs within the first 6 months. So I think being adherent to monitoring is also really important. And we had a very sad case recently of a patient who was non-adherent to monitoring, who stopped therapy and with an attempt at treatment-free remission and just did not come back for testing for 2 years and represented in lymphoid blast phase. So I think this is the issue, and this is the problem. So they have to, all of the guidelines state that you have the guidelines for qualifying for the patient, as well as having good access to molecular monitoring. So I think that's something that you would have to determine and discuss with the patient, that is it feasible to have regular monitoring in this case. Also there's many studies that show that the longer the patients are on TKI, the higher the chance of maintaining treatment-free remission. So there's a lot of issues for this patient before they would stop it. And in particular I think is the monitoring frequency. If this can't be done optimally, then the patient may risk a poor outcome.
Okay, thank you.
Isabel, what are your thoughts? And as you gather your thoughts to the audience, in the chat, if you'd prefer to post questions in Spanish or in Portuguese, that's absolutely fine. We have a number of other participants who can come in and translate for us. So feel free, please, to use the chat or use your virtual hand to ask questions or make comments. Isabel, what are your thoughts on this case?
I think that this case from diagnosis was a high-risk patient by so-called risk stratification, first of all. Then he developed the T315I mutation under DASA. But he responded very well to PONA. So if I think, no, if we put the patient under a TFR protocol, he must be evaluated monthly in order to take care of him and his evolution.
Yes.
I think it's difficult for the patient and the situation of the patient, and thinking upon his very high risk and his natural history of the pathology is high risk. So a very well evaluation must be done in this case.
Thanks, Isabel.
Monitoring, yes.
Thank you.
Thank you, Isabel. I'll invite Jerry to comment, but also a question from Mariana Lorenzo. For low percentage BCR able, would you recommend NGS instead of Sanger for mutational analysis? Jerry, what are your thoughts on the case and the question?
All right, so I had the same reaction as Sue did. I wrote down on my thing, the first thing I wrote is repeat the test because it's very, very strange. First we say that if you're an MR3, you should be in a safe haven where things like this don't happen, unless you're not taking your drug. And so that's usually that's the only reason they escape out of MR3. But certainly having a T315I mutation in this context is strange. I I would have certainly repeated the test. I probably would have repeated the test with a different method. As you might remember a number of years ago, there was a particular lab that was reporting on the phenomenon of having T315 mutations in newly diagnosed Philadelphia positive ALL patients, not exposed to TKIs at all, which didn't make a lot of sense biologically. And I think that seems to have been an artifact of the assay that they were using, which was an allele-specific amplification method, which is very sensitive, but is fraught for some false positives. So I probably would have repeated it in the same lab and in a different lab with a different method to really prove it. Even that being said, I may have even watched the patient, because it's such a strange case, I may have watched him a little bit more before switching to Panda, because it's not the easiest drug to have on a 48-year-old who presumably would have to take it for a long, long time. So those were my major thoughts on that case. It's a very odd case. But that's what we look for, right? And the question again, Ryan?
I think at the time I didn't think of repeating it, but it would have been hard for him to take the test and not switch and wait to rise. Or I could have waited another 3 months maybe, but the drug was available and was just arriving in Chile at the time.
Yeah, sure.
I have a question, may I ask?
Of course, Katja.
Thank you for the hello everybody. Thank you for the nice presentation. I just want to know for all the participants, what are you doing in the routine practice? Are you using NGS for everybody, or you still do Sanger sequencing and for the other cases that are low transcript levels, you use NGS? What you do in the real life and for your daily routine care of the CML patients in our countries?
So we might start with you.
So we're still doing Sanger sequencing. I think it's still a good method. For BCR-ABL levels that are very low level, we can detect high level, anything above 10 to 15%. But having said that, we are developing an NGS method to detect lower levels. So we will be introducing that over the next few years. Few months. We're just developing that method and validating. And one of the things that has prevented us from doing that is how do we fit it into the routine schedule? So we're sort of pooling with other tests, other NGS tests. That was the best way for us to do that. But I think if you do introduce an NGS, you have to have very thorough validation, have to make sure that you carefully determine the limit of detection so that you don't report false positives, because I think that is an issue with NGS, that you do see a lot of low level sort of background mutations as well that need to be recognized.
Jerry.
So I'm in Sue's camp that I think Sanger's for clinical testing is a fine assay. That being said, we're converting simply because we have two sequencing machines that are going daily to do patients with myeloid malignancy in clinical trials with a 72-hour turnaround time. So the machines run it all the time. So we just throw it on that, and so we get the ABL, and we get 50 other genes and all the various transcripts and fusion stuff at the same time. I would think that most settings that's not very cost effective, but we're really not paying for it. So that's why we do it. In addition to underlying Sue stuff, the validation stuff is really important on the next generation sequencing machines. Especially when you want to look at linearity. So, most of the panels when the people put out, they've only tested linearity like say 100% down to 1/1,000 stuff over a select group of genes. Most places, Illumina, other ones, haven't done on every locus. And if you do that, you'll find some genes that behave nicely and are linear, and some that have all sorts of sigmoid effects. And that's important because when you start looking at multiple things and are comparing VAFs, you might say, oh, this patient, and that's interesting. They have two different clones of disease because one's at a 50% and one's at a 30%. That isn't true at all. That depends completely on what loci you're looking at. So you have to be really careful. And in the validation that we did for the FDA on this Genexus machine that panel we use, it's a lot of data. The report to the FDA was 1,400 pages of data. So it's a lot of work.
Yeah, I can imagine. Thank you.
A couple of questions coming through on the chat. Vanueza Funk from Brazil says there are some case reports of mainly lymphoid sudden blast crisis after TFR. Is there any hypothesis for that? Lilian, what do you think?
Recently, there was the same discussion in the CML Foundation, a case from, I don't remember, I think India, where they said that the experts that you have to follow the most important transcript in CML, that's P210, but I don't know all the details and the arguments for that, so I would leave it for Dr. Radich.
It's really fascinating, and multiple centers have seen that. Our consortium have had a few of these. They're in our experience, they've typically been in patients who shouldn't have gone on TFR in the first place. There are people who have not been in a long, durable remission and have gotten off drugs and not been monitored very carefully. So it may be a little bit different issue. I'm not aware yet of anyone who's been like in BCR-ABL negative for like 10 years and then got off therapy. Those people blasting off. But it does seem like there's way more lymphoid than you'd expect. And I don't know what the biology of that is at all.
Stu.
Sorry, I was looking at the other question with the two types of transcripts.
Let's go for that then, and then we'll come back to Sue, who has been looking intently at the chat and would like to comment. But Lilian, you want to go first, and then Sue, please. And feel free to take on any of those questions in the chat without me having to recite them.
No. I was the answer I made for before. I was for this question where they asked for the types of transcripts to monitor when you have two types of transcripts. So there you monitor the P210.
Yeah, so this is a question about a patient who has the P210 and P190, so very low levels of P190. So this is very common, and I suggest that this patient just has the P210. So the P190 is just alternate splicing. So this has been recognized, I think, for over 2 decades, that this can happen. If you've got the P210 transcripts, you can quite frequently detect low levels of P190. So the patient doesn't actually have two transcripts. This is just alternate transcript of the P190. So in this case, P210 is what should be monitored.
Yeah. And in Philadelphia, I don't know about your strategies, Sue, but in our lab in clinical trials, in Philadelphia positive ALLs, we can have the P210 or P190. We do both up front. And then whatever transcript they have, we just follow that one. We don't follow both of them forever. We just pick the one they've got a diagnosis, and we haven't been burned yet with that. Although I've heard cases where it could potentially happen, but we just haven't seen it.
Yeah, same with us.
And perhaps a last question quickly before we move on. Mariana Lorenzo, do you have experience with nanopore tech? Who would like to comment on that?
With experience with what?
Nanopore tech.
Oh yeah. I don't know, Sue, have you anyone else that have done nanopore?
Just a little bit. We have done some long read sequencing in specific cases. So nanopore, we can sequence the BCR-ABL amplicon kinase domain. So we've just done this in a few cases, and the advantage of nanopore long read sequencing is that we can determine for patients who have more than one mutation in the kinase domain, we can determine if they are on the same allele or not. So whether they are compound. Yeah. So that's why we have tested a few patients. And so far, we have never detected any patients with compound mutations. So we see some patients who have multiple different subclones of mutations.
So whoever asks a question, we'd be happy to engage you on the nanopore stuff. We've been doing this for a few years. We've got papers out there on primer or probes and stuff for CML and AML and the like. And it's actually it's very fast. So recently we did an APL patient who had a call of the APL translocation in an hour, which is clinically really quite useful. So it's really pretty cool technology. It has its difficulties, which we can I won't go through here, but it's potentially really very impotent because using CRISPR to kind of do enrichment and the like, there's really no ceiling on how many targets you can go after potentially, at once. So I think it has a really great potential. But again, it's you have to, when you get into the nanopore stuff, you have to realize that their business model is everyone is a beta user. So there's not a lot of technical support on their end. So you can get the equipment and stuff, but essentially your technical supporter is all the other labs in the world who are also beta testers. So you have to be a little tolerant for that kind of stuff.
Thank you very much, Jerry. And I think that just about wraps up that first section there. Thank you very much to Professor Sue Branford and to Dr. Lilian Pilleux for leading a great discussion there. Our other experts too, thank you. That really was a wonderful discussion. To the audience, if you have any other unanswered questions from today, please get in touch with me and I'll endeavour to get a response to you.